one of the most exciting data that I actually have seen here at ASCO 2019 in colorectal cancer was a poster presentation, a poster discussion session hidden in the drug development section, and really didn't get a lot of attention by the GI community, of a combination of regorafenib plus nivolumab in treatment refractory patients with gastric cancer and colorectal cancer. And they were all, except for one patient, MSS tumors. One patient, colon cancer, had an MSI high cancer. And the response rate of 25 patients with metastatic colorectal cancer, MSS, was 33%, with a combination of regorafenib and nivolumab, which by themselves have very limited activity, actually probably low single-digit activity. And the waterfall plots they showed for the gastric cancer cohort and the colon cancer cohort and the durability of response was quite intriguing. Now, the regorafenib dose that was tolerable in this setting, which was a Japanese phase 1 study actually, was 80 milligrams in combination with full dose nivolumab. So it seems to be that for immune modulation, if we believe this effect, regorafenib can be actually dose reduced and has only limited toxicities at that point in time. I find these data quite intriguing. The question is it passing the threshold for, let's say, starting a phase 3 study, that would eventually be the gold standard for drug development? Or should we kind of expand this cohort now, let's say in a Western population, in the United States, et cetera, look for response rate as primary endpoint? The data are definitely intriguing, and I think they need to be pursued further.
So the rego-immune study was very interesting, although we have to keep in mind two elements that limit the excitement. One, was a Japanese-only study, so we don't know how this applies to the rest of the world. And two, this was a small study. And a reminder to all of us that the premise for the atezolizumab and cobimetinib study was a phase 1b study that started with a 20+ response rate, and by the end ended up with less than 10% response rate, but the phase 3 was already on its way. So we always have to take a step back. And this study included both gastric and colorectal, and gastric makes a lot of sense because both agents have activity that's meaningful. Regorafenib has activity, nivolumab has activity. In colorectal, regorafenib has some activity, but nivolumab in the MSS at least has zero activity. So unlike gastric cancer, where both work well and you put them together and you hope to see synergism, which was seen, in colorectal, I would remain a little bit more cautious because again, we have a drug in this setting that works okay, and we have another drug that doesn't work at all, and we put them together and suddenly it's magic. That does not hold the scientific test at this point of time. We need to understand a little bit better. Now, I do think that regorafenib offers a great partner to a PD-1 inhibitor, and the reasons are it hits VEGF, and we know VEGF and PD-1 seem to synergize well, but it also hits CSF1R, which I think is very important. It's one of the mechanisms that seem to drive even further the activity of PD-1 inhibitors, but it also hits a lot of other targets that may have relevance, and some we understand, others, most I would say, we don't understand, but they may have a role. So regorafenib and nivo, or regorafenib and pembro, or regorafenib and whatever PD-1, PD-L1 inhibitor is probably a rational combination to think moving forward. In microsatellite stable colorectal cancer, I think it's a reasonable strategy to explore. In gastric cancer, I think it needs to be explored. In colorectal cancer, I think it should be explored cautiously. I don't frankly believe that if you take really cold tumor, and we use just very simplistic terms, a really cold tumor that has no evidence of much activity, inflammatory activity, that suddenly you're going to make it warm or hot to have a response. I don't think those will ever respond, at least with what we have today. We have evidence that the intermediate tumor mutational burden, or perhaps even those high that are non-MSI high, or perhaps the CMS4 or some variation of the CMS4 patients, those may actually fit a good bucket of, I say, about 20% of the patients who may not respond really well to single agent PD-1, Those are the patients where you could actually perhaps move them from warm or warmish to hot, and then you can get the benefit in those. So I think when we look at the landscape in colorectal cancer and the microsatellite stable, we have to perhaps have a cautious approach, start with those a little bit more in a targeted fashion, and then for the other patients, perhaps explore as well separately. But I wouldn't really jump into phase 3 now or large phase 2, even a large phase 2 randomized study without having a little bit more data, because if the results of this Japanese study hold out, that certainly will transform how we treat patients with microsatellite stable colon cancer, even consider moving it up the line. So certainly exciting times. Caution needs to be applied, and I think the past, if the past tells us anything, is to be even more extra cautious with this group of patients and hold the excitement until we see more data.